Hi, Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine. Welcome to our video series for students. Once again, this is our office phone number, address, and Facebook page. And between those, probably the best way to communicate with us. And of course, you've already found our YouTube channel, so you can certainly feel free to communicate from there as well. But to be honest, I don't check messages quite as often from there as I do the other sites. If you would like to schedule a rotation with us in general pediatrics, either as part of an MD, NP, PA program, or DO program, feel free to give us a call at the phone number listed here. We'd be more than happy to have you. And if we're not already on staff with your university, that can be easily arranged as long as you're here in the United States, and usually Canada without a problem as well. If you're a parent, you're welcome, and we're happy to educate you as to what we're talking about here. Please realize that these videos don't replace visits with your doctor. We're happy to see your child here in this office, area code 775-359-7111. What we cannot do is help you over the internet or over the telephone, because quite honestly, that's just not good medical care. So what are we talking about today? Today, what I want to talk about is fever of unknown origin, or FUO. And I really want to look in fever of unknown origin greater than 60 days of age. The bacteriology and the epidemiology under 60 days of age, and really, it gets to be a little vague as to where that cutoff is. And some would say it's actually 28 days. But it gets to be kind of vague where that epidemiology shifts. But it's a very different disease definitely under 28 days of age, and to a certain extent under 60 days of age. So to keep things clear cut, we want to look at it over 60 days of age. And I'm going to reference a couple of papers, and we're going to reference them as we go. So the first paper is from McCarthy and Friends, Journal of Pediatrics, volume 70, 802 forward, from 1982. So a little bit of some old school pediatrics. This article is old. This article is still valid, however, and is a landmark article. So what did McCarthy look at? Well, what McCarthy looked at was something that we had known forever, which is that well-trained pediatricians, especially experienced pediatricians, can walk into a room and say, this kid looks sick, or this kid, especially in a patient with fever without source, this kid looks well. And that tended to correlate highly with someone who was septic or not septic. What McCarthy attempted to do was to quantitate the qualitative. And McCarthy attempted to do this for two reasons. One, to demonstrate whether a pediatrician's gestalt was accurate. I mean, we're assuming we know what we're looking at, but did we really? And number two was to establish good inclusion and exclusion criteria for further research in the field of fever without source, which was a major issue back in 1982. And so that's what they did. Now, McCarthy put together a scoring system and a threshold score beyond which your risk of sepsis, depending on what you set your threshold at, your risk of sepsis was, a certain percentage. The reality is, in clinical medicine, nobody assigns McCarthy scores. That's a research thing only used for inclusion and exclusion criteria. But the scale is still clinically valid. I just don't want to look at scoring it, because clinically the scoring doesn't mean a whole lot, but the components are important. And what I recommend to my students is not only look at these things, but chart these things. Don't just chart child looks well, child looks ill, child looks septic. Chart these details, because if ever you wind up in court, your charting will now be very ironclad. This is not defensive medicine. This is simply writing down what you're already doing. And a lot of so-called defensive medicine is really just that. It's just documenting what you've already done, not doing anything different, just writing it down. And I would recommend it. So what did McCarthy look at? Well, first thing McCarthy looked at was the quality of the cry. And they said, was it strong? Was it a whimper? Was it weak? Or a moan? Or high-pitched? Okay, the next thing McCarthy looked at was reaction to parent stimuli. So this was no cry, or cry, then stop. Cries off and on. Hardly responds or no response. The next thing McCarthy looked at was state variation. Were they awake? Or if they were asleep, did they wake up easily? Did they briefly close eyes? Or did they need prolonged stimulation to wake up? And then finally falls asleep or won't rouse. Next thing McCarthy looked at was color. Were they pink? Acrocyanosis? Or pale extremities? Or were they ashen, gray, mottled, or pale? And this is central pallor. Next, they looked at hydration. Mucous membranes moist, so MMM, mucous membranes moist. Skin and eyes normal, but tacky mucous membranes. Okay, or doughy, tenting, skin or mucous membranes dry, or sunken eyes. And, you know, people often ask me, what do you mean by doughy? If you have ever made bread after you let it rise, it's exactly what it feels like, is risen, raw bread dough. Now, before it rises, no, that's stiff and hard. But once it's risen and it's squishy, that's what it feels like. I bake a lot of bread because I like to cook, and it's kind of weird every time I feel it because it reminds me of patients who are sick. And then the last thing McCarthy looked at is response to social overture. I'm just going to put the word over here, but that's overture. So smiles. Under 2 to 4 months of age, they alert. Pay attention to you. Here, smile briefly. or alerts briefly. And here, no smile, no alerting, expressionless. Now, this set of criteria is still valid today and still useful today clinically, and to a certain extent still used today. And I really recommend this, not just actually with fever without source, but all patients, that you chart this for all patients who are sick, regardless of why they're here, whether they're febrile or not. It'll just keep you out of a lot of trouble, and it'll avoid missing a lot of things for a lot of people, and keep your patients healthier. The next large landmark in research of fever without source, or in the febrile infant, is what's known as the Rochester Criteria. And this came from Barif and McCarthy and Friends. Also in the journal Pediatrics. The next year. Oops, that's 92. Okay, so what they then did is took the kids, if they were ill-appearing according to the McCarthy scale, they were admitted to the hospital. They took the kids who were well-appearing and they said, of those who were well-appearing, who's septic? And what criteria can we use to determine who's septic? Well, first they had some historical criteria. Preemies, recent antibiotics, chronic illness, and hospitalization in the past. These all made you high risk. And if you had any of these, you didn't cross-go, did not collect $200, and no additional workup was necessary, you needed to be in the hospital, where more workup would be done, but we didn't have to worry about it being outpatient. Then they stratified patients. Okay, 28 to 90 days. If they were toxic appearing, they were admitted. And that's based off of the McCarthy scale. Non-toxic appearing, they got blood, urine, and CSF. Set up for chemistries and culture. The problem is, of course, cultures take several days to come back. There is no such thing as a stat culture. They then gave Rocephin, ceftriaxone for those of you who speak generic, or urine plus observation. But most of the time they were doing this because the goal is to determine who can go home. They defined a low-risk patient based off chemistries as white blood cell count 5,000 to 15,000, band count or stab count less than 1,500, and that's absolute band count. Urinalysis less than 5 white cells per high-powered field. If there was diarrhea present, same thing, less than 5 white cells per high-powered field. CSF, if it was done, same thing, less than 5 white cells per high-powered field. And if there were respiratory symptoms, chest x-ray was normal. All right, so then they looked at kids 91 days to 36 months. Toxic patients got admitted. Non-toxic. They looked at the temperature. So if the temperature was greater than 39, less than 39.0, they observed. And they were told, come back if your fever lasts for more than 2 hours. For kids with temperature greater than 39 degrees, they got urine. For culture, for males, less than 6 months. Females, less than 2 years. Stool culture if there was blood or mucus. Or greater than 5 white cells per high-powered field. And blood culture on all patients, or if the temperature was over 39 and they had greater than 15,000 WBCs. They gave antibiotics to all kids. Or some centers, this was a multi-center trial, if the temperature was greater than 39 degrees and the white blood cell count greater than 15,000, they would give the antibiotics. Now, the limitations to the McCarthy or to the Rochester Criteria are as follows. This was done before Haemophilus influenza vaccine. The majority of what they were looking for was Haemophilus influenza. These criteria are still valid if you have a patient who's not been vaccinated for whatever reason, or not fully vaccinated for whatever reason. But in a fully vaccinated population, don't mean quite as much. And for stuff like pneumococcus, which they were still seeing back in 1983, those patients didn't get so sick so fast and usually had other symptoms. So they didn't just have pneumococcal sepsis, they had pneumococcal pneumonia. So there was respiratory illness. That's not fever without source, that's fever with a source, fever with pneumonia. So, you know, they were guided already what to do. Whereas with Haemophilus, it was septicemia and meningitis that they were looking for. So clinically, there is no source. You're not coughing. You get an x-ray. It's normal. So that was what they did. With the advent of Haemophilus influenza vaccine and now pneumococcus vaccine and then later meningococcus vaccine conjugate, MCV4, these criteria are a little bit outdated, but I think it's important to understand where we came from and what we were looking at and what we were doing back in the dark days of 1983 so that we know where we're going and understand today's literature and can interpret it in an appropriate context. Which now brings us to the modern world and the one paper I want to discuss. There's many, but these are just the ones I want to discuss. Whoops. Let's fix that. So in the modern world, we want to look at Trottenauer, or Trotner, and Friends from Pediatrics. See, this article's even getting a little dated. "34, that's a 4, not a 9, to 40. And specifically, they were looking at risks of hyperpyrexia. which they defined as a temperature greater than 1060 Fahrenheit. Now, I've asked many a student with clinical background this, many a nurse this, and of course asked myself this: how many patients have you seen with temperatures over 106? And in my case, the total answer for me and all of my students is 1. Not very many. And that 1 we knew wasn't septic because he was back from really bad surgery. Really good surgeon, just really surgery nobody wants to have done, and he didn't do so well because patients don't do well with that surgery and don't do well with his underlying disease. So it wasn't a surprise to any of us when we saw that temperature. But they were looking at 106, okay? And let me just take a second here, depending on what you do for a living. Fever does not cause brain damage. Brain damage and diseases that cause brain damage, like meningococcus, can cause really high fever. But the fever itself is not causing your brain damage. The meningococcus and the inflammation in your brain is. And even if you were afebrile, the meningococcus in your brain would still damage your brain. Of those patients, approximately 18.4% had a bacterial infection that was found. Okay, and of all patients, and that was an N of 103 patients, of that same N, approximately 10% were found in the blood, and approximately 7% of the infections were urine. Okay, now this was at 106. The thing is, most of us don't wait till 106 to start doing our workup. We start doing our workups at 105.5 or even 104, depending on what our threshold is. And we don't have good stats as to what their percentages of positive cultures are at that point, but it's going to be less than these numbers. So at 104, maybe you're looking at like 5% blood and 2% urine. And at 103.5, you're maybe looking at 2% blood and 1% urine. But that's based off gross estimates. There's no good research at this. And again, these are patients with fever without source. That means in flu season, they're rapid flu negative. That means if they've got sore throat to go with it, they're rapid strep negative. That means they don't have cough. Because if they have cough, then it's a pulmonary infection. It's not a fever without source. This means they're not having diarrhea. They're not having gastroenteritis. They don't already have a known UTI that got away from us, kind of thing. So in the modern world, in fully vaccinated patients, the money is on urine culture and perhaps blood culture. But unless the kid's starting to show some signs from the McCarthy scale, we don't need to give antibiotics until something comes up positive, and then we treat it. My personal practice is somewhere between 103.5, 104 in a patient who doesn't have flu, because it's either not flu season or they're rapid flu negative, and who doesn't have Coxsackie virus, which will also give you really high fevers. Or at least doesn't have known Coxsackie virus. It's rough during Coxsackie season if somebody comes in and they don't have herp angina or hand, foot, and mouth disease to know that they have Coxsackie, and we wind up doing a lot of urines on those patients to, at the very least, get the urine and then depending on the scenario and how much I can assure the follow-up to get the blood. So I think this is all I want to say about fever without source. And I think this pretty much completes our discussion. I hope this has helped to elucidate this. I do recommend you look at those papers. Oopsie. There we go. So please don't rely on my discussion. Please look at the literature. And of course, new literature is being released every single day. This is just the landmark stuff that I want you to know at this point in time, but it's hardly complete. Again, if we can be of assistance here, give us a call at 359-7111 if you'd like to rotate with us. We're more than happy to have you here. And remember, we can't help you or your patient or your child over the internet, but we're more than happy to consult with your patient here in the office. Have a good afternoon, and we'll see you next time. We've got a couple of other interesting videos coming up.